Good morning, everyone from Paris, OECD, and Berlin. The recent publication of PISA results is still on many people's minds, but of course, skills, competencies, literacy have many dimensions, and one of them is health literacy, which we are going to look into today. And I'm very happy that our Deputy Secretary General Yoshiki Takeyoshi will briefly introduce us to the subject, and this will be followed by a presentation of the main results that we presented in the recently released Skills Outlook by Mark Pearson, who's the Deputy Director of our Employment, Labor and Social Affairs Directorate. Dear Deputy Secretary General, please, the floor is yours, and we're looking forward to what you have to tell us about health literacy today.
Well, thank you very much, ladies and gentlemen. Thank you for joining us online for this webinar on promoting health literacy to reduce health inequalities and address the increasing burden of disease. The COVID-19 pandemic had shown us how important it is that everyone is able to use health information to protect themselves and others. Health literacy becomes even more important in the age of AI. Advances in AI provides us with unprecedented access to health information and tools that allows us to monitor and manage our health and well-being. In this context, health literacy is needed to sift through an overabundance of health information, some of which can be inaccurate. The 2023 OECD Skills Outlook on skills for resilient, green, and digital transition provides evidence on the distribution of health literacy in adult population and the important role health literacy plays in shaping health outcomes. The OECD is also leading efforts in the measurement of prerequisites of health literacy. The 2022 edition of Program for International Student Assessment, PISA, we launched last week, shows that many young people at age 15 remains ill-equipped to use their skills to meet the real-life challenges. We also see that while the capabilities of AI systems continue to improve at an impressive speed, there are a major decline in PISA test achievement between 2018 and 2022. For example, as many as 31% of students in OECD countries did not reach the baseline PISA proficiency level in mathematics, and achievements in mathematics dropped by 15 score points between 2018 and 2022. The pandemic played a role, of course, but other factors are responsible too. I urge us all to see the critical role of health literacy in improving population health and work to increase the uptake of health literacy surveys and assessments. One of the reasons why PISA is able to contribute to the important policy dialogue in education is that it provides evidence on progress on over 80 education systems worldwide. The MPO network is doing excellent work in this area through its health literacy study, and it would be fantastic to see greater coverage in the future to strengthen this knowledge base on these critical skills of individuals and societies. At the upcoming OECD Health Ministerial meeting in January 2024, ministers will discuss how to make health systems more resilient to future shocks and stresses, such as pandemic, climate change, demographic change, and digitalization. As I'm sure you will agree, health literacy contributes to all of these goals, and we look forward to the best practices that ministers will share. So I very much look forward to a rich discussion today. We will start with a presentation by Mark Pearson, the Deputy Director of the Directorate for Employment, Labor and Social Affairs, of the key findings from the Skills Outlook 2023 report on our public health work. We will then continue with a discussion on what countries are doing to strengthen the health literacy skills of individuals and empower them to manage their health. I am looking forward to learning from Peter Nowak about what happened in Austria during our panel discussion. We will then discuss debunking fake news as early and as efficiently as possible and help citizens make the right choice for their health. In 2003, the term infodemic was coined to describe a situation in which too much false and misleading information spreads rapidly, making it harder for individuals to engage in health-enhancing decisions. This term gained renewed popularity with the outbreak of COVID-19 pandemic. You may remember how, particularly in the early phase of the pandemic, the social media networks were flooded with most bizarre news and advice, in some cases, not only with useless, but also harmful suggestions. Ola Isaac will provide further insights into how the WHO is setting up counter campaign to fight fake news. But health literacy is not just critical to build resilience and preparedness. Making information accessible and actionable is critical also to empower people to engage in healthy behaviors that reduce the incidence of non-communicable diseases. Viet Yang Tang will provide examples of how social media can be used to reduce engagement in unhealthy behaviors such as smoking or drinking. Dear all, protecting the health of individuals is a challenge and requires the concerted effort of governments, health professionals, as well as individuals. I am delighted that we are able to drive this discussion forward today, building on findings of the 2023 Skills Outlook and exchange ideas to learn from each other. I will now pass the floor back to Nicola. Thank you very much.
Thank you very much, Deputy Secretary General. And well, without further ado, Mark, I give you not the floor, but the screen, and we look forward to seeing the results that you can present to us today.
Wonderful. Thank you very much, Nicola. Good morning, everybody. Afternoon, for those of you in different time zones. I noticed lots of names that I recognize. Great to virtually see you all again. And those that I haven't met before, great to meet you virtually. Let me start sharing my screen. But whilst I'm doing that, you know, I have a 23-year-old daughter who lives in London, and every time she calls, nearly every time she calls, our conversation usually starts with her self-diagnosis of all the wonderful diseases she's managed to catch since we last spoke. Nearly always wrong, of course, but I think that, you know, she's an intelligent woman, first-class degree, top university. But health information, it's complex for individuals to filter. It's expressed often using scientific terminology, technical details. What's reliable? New technologies blurring the line between credible and unreliable sources, between true, misleading, and false information. And you know, many health decisions today require individuals to choose and follow really quite complex regimens. And that, again, increases the complexity of health decision-making. So what I'm going to do today, I'm going to present work not by me, and acknowledge straight off it's by Francesca Borgonovi and her team. Really worth reading, the Skills Outlook, for those of you who haven't come across it before. So this is not being produced by the health team, it's produced by the skills team. It gives a slightly different angle maybe on how we sometimes talk about health literacy and public health. Let me give you some of the key findings about what we know about health literacy, and indeed about use of information online more generally. And the Skills Outlook shows that around 6 in 10 adults in OECD countries are worried about receiving false information online, and it goes up to as many as 8 out of 10 in Italy. So quite a lot of concern out there. And again, just in the context of giving this sort of background information, we know that we have a quite big tail in many countries of people who really have only quite basic information. This data here is basic knowledge. This information is based on something called the PIAC survey, which is a massive survey of foundational skills of adults about whether they're able to effectively access, filter, evaluate, and use information. And what it showed,
sorry to interrupt, but we can't see this. We can't see your slides yet.
You can't see them.
No. Yeah.
And
so
yet,
I think you still have to share the screen.
yeah, I've already done that. This is not the first time this has happened.
I'll share on my side, Mark. Just say next slide when you want.
Yeah, I'm pressing share again. I've pressed it now 4 times. Let me try that one.
That's good.
Oh,
well,
that's exactly what I've been doing.
And now go from beginning now. Can click from
really
beginning.
annoying.
Good.
There you go. Thank you. Sorry, I was doing the right thing. It just failed to work. I don't know what's happening this morning at the OECD. It's great fun. That was the first one where I was showing the 6 out of 10, 8 out of 10 in Italy. This is the one I was coming on to just talk about the PIAC survey about basic skills, information processing skills, showing that 16% of adults in OECD countries have only very low levels of proficiency in both literacy and numeracy. So I think, our starting point here is that people with low levels of proficiency, we would expect to struggle with dealing with health literacy. What do we mean by health literacy? Well, information processing skills are necessary but not sufficient to make the most of information to enhance one's health. Health literacy is needed. And our definition here is the knowledge, motivation, and competencies to access, understand, appraise, and apply health information to make judgments and take decisions in everyday life concerning healthcare, disease prevention, and health promotion to maintain or improve quality of life throughout the course of life. The reason why health literacy, of course, is getting a lot of attention these days is really because of its potential to reduce incidence of health conditions with a large disability burden, and indeed also to reduce inequalities in health access and health outcomes. I was just at a meeting in Tallinn earlier this week, organized by the WHO, and health literacy was coming up all the time in the context of trust in the health system and in how you can get support for transforming health systems. So incredibly important. Hang on, well, I'm missing a slide in this version of the presentation. I mean, the way that we measure health literacy is being used by using the MPOL survey, the WHO Action Network 2021, using HLS 19. And in this survey, participants were asked to indicate how easy or difficult they found it performing a series of 12 general health literacy tasks. And the answers were based on a 4-point, for those interested in these things, 4-point Likert scale, with the options being very easy, difficult, and very difficult. And on average, individuals found it most difficult to judge the advantages and disadvantages of different treatment options. About 44% struggled there. Deciding how you can protect yourself from illness using information from the mass media, 42% struggled there, and finding information on how to handle mental health problems was 38%. But only 8% indicated that they would find it very difficult to act on advice from their doctor or pharmacist. That's that slide, which comes later on in this particular version of the slide. Now, I think what's particularly interesting in this is that the differences in health literacy by socioeconomic characteristics such as gender and age are really quite small. And really surprising, I think, is that the differences by educational attainment are really minor. That's so unusual when we look at skills. Now, there are differences. I mean, I'm not saying that there are no differences, but some differences in particular by self-reported financial deprivation. You can see those bar chart bars there in the bottom right-hand corner. The gaps are a little bit bigger. So on average, individuals with no or some financial deprivation perceived 79% of them of their health literacy tasks as very easy or easy, whereas those with considerable or severe financial deprivation, it was 68% of those health literacy tasks were easy or very easy. So there are some differences there. Let's go backwards now to this slide, which I think is really quite telling, as it's looking at the impact of health literacy on actual behaviors. And what we know that obesity obviously is a massive health challenge. About 1 in 4 people in OECD countries suffer from obesity or overweight, and individuals with higher levels of health literacy are indeed more inclined to engage in healthier lifestyles. In this case, we're looking at physical activity, but it's also true if we look at consumption of fruits and vegetables. And so again, using the HLS 19 OECD countries, there's a difference of 10 percentage points in the number of health literacy tasks individuals perceive as very easy or easy. If you have that difference, it's associated with an increase in the likelihood that respondents reported exercising at least 4 days a week. And even when you then harmonize absolutely everything, so you're basically saying that people with the same age, same gender, same level of education attainment, same levels of financial deprivation, the people who have higher levels of health literacy are about 2 percentage points more likely to engage in 4 days of exercise a week, which doesn't sound much, but on a population-based level, 2 percentage points actually makes a difference, to the real difference to the number of people who are suffering health consequences of obesity. The potential for using health literacy, people who are more health literate in co-production of health, as the jargon goes, in supporting, contributing in their own healthcare in order to achieve better health. The potential is absolutely enormous. Obesity is kind of the obvious one that immediately people think about, but here we've got the list of preventable deaths, and if you look at it, the vast majority of them, preventable deaths, are caused by risk factors which can be shaped by health literacy. At least half those top 20 risk factors directly impacted by individual levels of health literacy, things like tobacco use, alcohol, drug use, patterns of diet and physical activity. You put all these risk factors together, and it's possible to assert, as it says on the slide there, that health literacy has an impact on about 75% of the deaths taking place in the OECD. Now, I'm not saying that we're going to prevent all those deaths. Of course, it's absolutely absurd. On the other hand, it shows the potential for maybe improving health literacy and involving people more in order to tackle these risk factors. So what do we know about investment? We've calculated the impacts of scaling up best practices to promote health literacy to the national level and across 27 EU member states. And the sort of things we've looked at there, I'm not going to go into huge detail, it's quite technical work, but you can see there some of the things we looked at about improving Nutri-Score, about education-based interventions to promote an active lifestyle. And many of the interventions really combine both action to improve health literacy with changes in the health environments, the environment more generally, to make it easier for people to choose healthier options. And what the graph on the left is showing is that scaling up these measures from local communities where they've been trialed to all of the EU 27 countries could prevent almost 2 million cases of non-communicable diseases by 2050. And the chart on the right shows the health improvements that this would generate. It could generate healthcare expenditure savings of between £0.5 to €1 per capita per year, and increase workforce productivity by around €0.5 to €3 per capita per year. That sounds again like small numbers, but this is evidence-based. We know we can achieve this, and actually in health, finding strong evidence like this is quite hard, quite rare to be able to come up with numbers like this, and so I think these should be taken really quite seriously. How can we ensure that technological innovations lead to improved health? Look, I mean, the sort of things discussed in the Skills Outlook are of course, the development of health literacy throughout the life cycle. I mean, here we're just focusing on young people, and I think, the fact that only 54% of 15-year-olds in OECD countries are at the moment being taught strategies to detect whether online information is subjective or biased is really quite shocking, as for some reason I assume that number would be much higher, as it is, indeed it is in countries like the United States and Australia. But it shows that there's a lot more that can be done to help young people actually identify whether the information that they're receiving online actually is reliable or not. And that's obviously a foundation for way beyond health literacy, but absolutely necessary for health literacy as well. Moving more directly into the health area, improving the accessibility of health-related information, I think, is something we can do much better, and where there is much more information available about what works these days. Countries are increasingly, of course, you all see them, the food labels to tackle unhealthy diets, for example, by providing information which is easier for people to understand with any level of health literacy. Now, the objective here is often to encourage the food producers to reformulate rather than necessarily directly affect the behavior of individuals. But nevertheless, our work shows that easier to understand labeling schemes can have quite high impact in steering purchasers to select healthier options. And I do think that also we could do better in doing this across countries as well. You'd expect the OECD to say that, but I think promoting better cross-country comparable information would be highly desirable. I'm sure we're going to hear a lot more about this later. I think Peter's going to have more to say on what we can do about making health-related information more accessible. And want to acknowledge yet again the work of the MPOL network for developing the health literacy study. I think it's absolutely fantastic. Really hope that we have more countries involved in that project in the future. I'll stop there, Nicola. I'm very happy to contribute to the discussion later, but I think it'd be great to hear from some of the real experts in this area. Thanks.
That's great. Thank you very much, Mark. Perfect. So now we're going to discuss these very interesting findings with our experts. So I have with me now Peter Novak, who is from the head of the Competence Center Health Promotion and Healthcare at Gesundheit Österreich, so Health Austria. Ola Ishik is a Risk Communication Officer at WHO. And Viet Nguyen Tan is the head of the Addiction Unit and Health Promotion and Prevention Division at Santé Publique France. So I would say probably the equivalent of Gesundheit Österreich in some ways. And Peter, perhaps I can start with you, because I think health literacy improvement is really one of the objectives that health policy in Austria has, and you have national targets there. And I just wanted to ask you, it's interesting to see, as Mark has shown us, how important it is and how influential it can be if people are actually health literate. But what does that mean? So how do you promote health literacy in Austria? What are the targets, and what are perhaps some of the experiences that you can share?
Thank you, Nicola, and thank you, Mark, for this wonderful presentation. Actually, in my department, my competence center is the scientific coordination of the AMPOL network. So I'm very happy you really showed how important this is. And 23 countries are working together here. So, and more are invited, actually. But coming to Austria, and from hearing all what Mark just was presenting, I just go back to the first European survey, which was in 2011. And this was instrumental for the Austrian situation. An Austrian team at this point was also the core of the scientific part of this. And Jürgen Pelikan, who was the scientific lead at that time, he started, we had the results for Austria. Austria was, of these 8 countries, it was on the 7th place. So there was Bulgaria, and all the other countries were better. So this was quite shocking for Austria. I think we are well developed in our healthcare. We have a lot of expenditures for the healthcare system. And now people, and more than half of the population, said, we don't understand this system. So this was shocking for policy. And it was by some auspicious coincidence, if you want, that Jürgen Pelikan presented that to the policymakers in Austria, and there was a reform going on in the Austrian healthcare system, and they said, oh, this is something very important and we have to do something. And with this opportunity, we started in 2015 then an Austrian Alliance for Health Literacy. And this was actually the very important step to establish a coordination institution on a national level to bring together all the stakeholders to work together here. And so this is very important to learn from Austria. It is in Austria, we have a very complex healthcare system, which is, so it's the federal government, it is the Bundesländer, which is the provinces, and the Social Security, who works together for the healthcare system in a very complex way. So, and we needed to get together all these partners to say, this is important, we have to do something for the health literacy in Austria. And the main areas of intervention we developed in the last years are 4. So the one is to develop the professional communication of health professionals. So people usually are only interested in health when they are sick, most of them. So it's very important what doctors and nurses are telling them, and are they understood, and can people apply what they hear? And I could speak a lot about. So up to now, we have built up a training system for communication trainings for health professionals. At the point, we now have about 7,000 health professionals trained on an international level, which is not much, and at the same time, it's a lot. Yeah, but a lot to do. So it's 150,000 healthcare professionals in Austria. So we are just at the start. The second one is to develop easy to access and understandable health information on the media, in brochures, whatever you have, especially in the digital world, websites, apps, etc. So I can go back to this later maybe. So we developed some standards here, And the third intervention level is how to develop what we call health literate organizations, and especially health literate healthcare organizations, but also schools and others. So organizations who put health literacy on their top priority agenda. And the last one is to empower directly patients and the population, which is their own world to deal with. So these are the main areas we developed. And we can see from the data from the first survey in 2011 and now with HLS 19, which Mark was referring to a lot, we have an increase of 5% in Austria on a population level, which is really good. So there, of course, there are many questions to these data on the scientific level, but I think we really were very successful with these strategies. So maybe I stop here and others should add to this.
Yes, brilliant. Thanks, Peter. The only follow-up question I have for now, and then we can, take it into a second round is, so you have the strategy to really promote health literacy. Are other countries doing similar things? Is that a widespread approach to develop a strategy so that at a population level, health literacy improves?
Yeah, there are other countries in very different situations. You always have to consider the specific policy background. Actually, the AMPOL network is just developing a guide on health policy decision-making on health literacy that should be published in January, where we put together all the experiences of the AMPOL countries in how to develop on a national level health literacy policies. But you could say maybe it's Norway, Portugal, in some way Germany, but Germany is always a story in itself. There is Ireland. So there are some countries who really work with national action plans, with own institutions, like in Austria, coordinating this. So yeah, I think maybe these are very good examples of practice. Portugal, Norway, Ireland would be some of my first champions here.
Perfect. Thanks, Peter. And I think I want to move to another point that the Deputy Secretary General mentioned briefly in his introduction, Olya, and addressing this question to you. So we've talked about health emergency, COVID being one obvious example, and we know that people can get very excited and nervous, and sometimes the internet and other information channels can be flooded with information that's more or less reliable. And you are specializing on promoting health literacy in emergencies, in different emergencies, not only COVID, but we'd be interesting to learn what the WHO does in this area and what's important to keep in mind for individuals perhaps, but also for countries, how to steer a population through a health emergency.
Thank you very much. This is a great question, and indeed something that I am focusing on in my work. I work with the WHO emergency program in Europe, and based on many lessons that were identified and some learned during COVID, we would like to build this work around health literacy in emergencies, because it's critical. I think that when there are many definitions, of course, of health literacy, what it is, and there are many areas in which we're looking into health literacy. They're all equally important, but emergency has, of course, some of the characteristics that are important to consider when talking about health emergencies. First of all, people have to take very quick decisions to protect their health and well-being. And then through health literacy, we should enable them, and I like that Peter just used the word empower individuals to make these health decisions, because In the context of emergency, obviously, we do not have time. It has to be done quick, and many studies show that higher health literacy, of course, contributes to better resilience of communities also, and it can better protect vulnerable population. Another important characteristic of emergencies that we should consider is uncertainty, because very often we deal with uncertainty. While, for example, we're talking about obesity, there is more information there and it's slightly easier to navigate. But for example, COVID showed how fast situation develops and involves, and the recommendations of academia, health institutions, governments change a lot because the situation evolves and we know more information. Therefore, it's also important to help people navigate this uncertainty and kind of embrace it, to acknowledge that we will have to face it, and again, support people with that. I think that again, very important is not to put burden on individuals. I think that it's a absolutely shared responsibility, and all stakeholders of our society have a role to play. As WHO, we are now working on developing policy recommendations for health authorities on how they can empower people during emergencies to navigate information. And we really believe that health literacy should be part of national preparedness and response plans, for example, with different elements. Peter mentioned them. I think we all know them. It's accessible information, credible information, user-friendly information. We talk here a lot about digital health literacy, but I think it's also important to understand that in emergency situations, very often, even countries who have very high digital literacy and digital access to digital services, those services might be interrupted. And also, how do we make sure that other accessible domains of information are available for people? So making sure that as health authorities or governments or health institutions, we enable people to access information in a plain language, very, very simple. And then, of course, communities are also central to that, because they help us to engage with different groups, different vulnerable groups who are absolutely critical. And we also need to understand their needs and tailor our information to what they need. So there is a lot to that. And I think that a lot of work is being done. There is more to be done. But we also, I would like to kind of wrap up that we are now finalizing a literature review that actually looks into what we learned or observed during COVID-19, but a little bit broader on health literacy in emergencies, and what are some of the practices that we can make sure that we use in the nearest future for preparedness and other emergency response cycles, to make sure that it's scientifically based and also has very practical and operational mean as well.
Perfect. Thank you very much. And I think what I would like to delve into now with you, Viet, is so we heard from Mark that health literacy, strengthening health literacy can be extremely powerful, in particular in making it clear to people how important it is to engage in some healthier lifestyles, because then we can have a better handle on obesity and all the chronic diseases that come with it, so heart diseases and other chronic diseases. And you lead a program that is spearheaded by Santé Publique, Moi Sans Tabac, so me without tobacco. Yeah, it would be great to hear how you go about this, or how you perhaps monitor results, and what are the results? Does it really have a tangible impact? What can other institutions like yours learn from that?
Thank you very much, Nicola. First, I would like to thank OECD for organizing such a very interesting webinar. I think I'm going to learn many things thanks to the excellent panel of experts that you have gathered this morning or this afternoon for some of those. So thank you for inviting me. It's really an honor and a pleasure to be with you today. Yes, Santé Publique France has been running a social marketing campaign which is called Moi sans tabac. So it can be translated by Me Without Tobacco or Month Without Tobacco. It's been running for 8 years now. It's been created in 2016. It's actually an adaptation of the British Stoptober that some of you may know. It consists in proposing every smoker in France to quit altogether for 1 month in November. So this campaign is based on the principle of social contagion. We try to make quit attempts a sort of epidemic, not disease, but on the contrary, positive behavior, health behavior that spreads around the society and among the smokers. One very important issue that we have in France regarding tobacco, and I think it's the case in many other countries, is that social inequalities related to smoking are very high. I'll give you a few numbers. In 2022, 24% of the adult population are daily smokers in France, but there were only 17% among those with the highest incomes, compared to 31% among those with the lowest incomes. So those social inequalities and while the health literacy issues that are underpinned under these observations, it's a priority for us. And it's a priority for all our social marketing campaigns regarding tobacco to try to tackle these social inequalities. To do so, we try to respect the principle of proportionate universalism stated by Sir Michael Marmot, that I think many of you know maybe better than me. So that means that in our social marketing campaigns, we address all French smokers, but we try to make special efforts to reach and to help the most deprived ones. It's very important. It means that we design our messages so that our priority target who are low socioeconomic status smokers can identify to see situation and characters that are displayed in our campaigns. We also choose the words, the sentences, the images, the pictograms that we display in our campaign very carefully so that they can be understandable by the most deprived ones. And another very important thing is that we try to display our messages in the right media. We have to be where the most deprived are. We have to use the media that are used by the low socioeconomic status smokers, which means that, again, still today in 2023, we use a lot television. It can seem old-fashioned because it's an old media compared to social networks, social media, digital communication. We use these more modern medias as well, but our data shows that television is still one of the more effective ways to reach the most deprived smokers in France. So we engage in massive communication on television by using classic TV ads, and also by trying to set up partnerships with channels and with TV personalities who are popular among low SES smokers, so that they could endorse and bring our messages to smokers. And it's important because it's a very effective way to reach those population and to engage them and to help them apply the information that we deliver and, well, convert it into healthy behaviors and quit attempts.
That's great, and that's very interesting that you say it's good to transport the message via popular personalities. I have from the audience a question which is perhaps a bit related to your campaign, from Michael Schwarz, who's asking, so how to reach vulnerable groups? You just explained television works well in France because you have data showing that this is used. But he's also asking about migrant populations, and his conjecture is that migrants are sometimes digitally more literate than the welcoming society. So is that something you can confirm, or do you have different data for France? Do you have specific data for migrant populations who are in many countries, I think including France, often of a lower socioeconomic status? So basically your target population, if I understood you correctly.
Yeah, that's a very good question. I may not have all the answers, but so I may let Peter or Ola react to this question. But I can give you a few elements of response. Maybe not related to the population of migrants, because we don't work very much with other partners who are in link with those populations, but more broadly regarding vulnerable populations, it makes me think of a very important fact, which is that to be effective in influencing behaviors of the population, it's not enough to be in the media. We also have to be present in real life settings, and we have to bring our messages and our concrete help the closest as possible to where people are. So being in the media is, I think, necessary, but it's not enough. And we try to engage as though in partnership with field officers, health professionals and social workers as well, who are connected and who work with those populations every day. And we try to convince them and to help them bring our healthy behavior messages as well. So then that's one part of the answer we can give, I think.
Perfect. And I think Ola wants to come in, jump in. So that's perfect. We want to be spontaneous and bring in all the information we have. Ola. And
Thank
Peter
you.
too.
I think it's a great question, and I just like to add overall. I think that engaging various vulnerable population, including migrants, of course, in co-creation of messages and co-development of interventions is critical. And we have seen it that if we want to be most effective with reaching our messages or interventions or whatever it is to these populations, to different populations, it doesn't matter what kind of community group it is. I think it's very important to map them, identify influencers, and influencers, by influencers, I mean, of course, opinion leaders, those people who can help these communities make the decision about their health, because it will resonate with them more. And I think one important point that is kind of obvious, I'm sorry for stating the obvious, but from my experience, is often overlooked, is language, especially when we talk about migrants. And if it's a migrant in a I don't know, let's say French-speaking country, of course they need to know the language of the country where they are, but very often, especially health information, can be quite difficult to navigate. And I think this is important when we work with the vulnerable populations to remember and recognize that it's important to speak to them in the language that is appropriate for them, and also ensure cultural that our information and communication is tailored to the cultural context of these populations. Thank you.
Yeah, maybe I add to this. I think the main points already were mentioned, but is you have to find the right media people are really looking in, and these are different. Migrants are not migrants. So we have very different groups with very different uses of media. And so that's one point. The language is already said, but the main point we just do a little bit in Austria here, because there are so many different communities here. And the main point is to find in the community leading persons who would be, in a way, the champions or the people who lead information into this. And that could be in some, we have some projects with African communities, and the old mamas are important, you know, and you have to get access to them, then you can provide the information. So these are very different. And there is this second chat coming from Miguel from Portugal, who is actually the leading person for health literacy. Miguel is here. And what I learned from Portugal, and it's important in this context, is during the pandemic, they developed a network of health professionals, local health professionals, who would be informed on the newest information. So Ola was speaking about how to navigate uncertainty in such situations. So I think this is a model of really good practice in Portugal, that you have to develop the professional networks around that, so that the professionals would locally inform people. And I think this is so important, that we need to work with the professional networks first, and they would be the multiplier for such situations.
Perfect. Thank you, Peter. So we already learned a lot about how to use the right opinion leaders, be it in the professional network, grandmothers, celebrities. Very interesting. Mark, I have a follow-up question on your presentation, because I think, well, tobacco, right? It's relatively straightforward to understand that it's not so healthy. But then you showed some data on Nutri-scores and how that can improve health and productivity, etc. And I had this personal experience with the Nutri-score, I think last summer, with my kids who are less literate, younger and a lot less literate than your daughter. And they discovered some chocolate balls, you know, that you can eat for breakfast from a famous food company, I shall not name it, and it had a Nutri-score A. So they said, Mom, you can eat this, right? And then on the other hand, we were looking at some salmon, which I always thought is decently, so smoked salmon, and that was D. You know, I said, how is it possible? And I looked into it a little bit, and apparently it's partly because these scores are being given, but you correct me if I'm wrong, in the same food category. So I'm wondering, wow, I mean, yes, it looks straightforward, A, B, C, D, right? But if you dig a little bit deeper, it's a lot more complex. So I'm wondering, is it really easy information? Of course, sometimes when you have a complex problem, it's not easy to give easy information, but in some ways, I'm surprised by your really significant results there. Perhaps you can comment on it a little bit.
Yeah, no, I do understand why you find that peculiar, and of course, in some respects, I do too. I suppose what we should remember about when we see the food labeling is that the objective ultimately is to make food healthier, and actually one of the main ways of doing that isn't just by changing individuals' behavior, it's by persuading the companies to reformulate. And that actually does work. Companies are they certainly understand all the ins and outs of how to get a particular score. And if you, of course, you can encourage companies to reformulate their products to become healthier, you've got an easy win in terms of improving nutrition. And so those Nutri-scores, yes, they are related to health literacy. They have to clearly be useful enough that people will look at the labels and actually think they're going to take them into account. But it's not necessarily the individual behavior that is the objective of the policy here. It is something a little bit different. I mean, that said, of course, you're quite right to say that there's a balance to be had here. I mean, food labels what we found is just putting information, all the information, you know, the great long ingredients list and everything like that. People don't really read them. I mean, not enough. And so you need to have something that's simple enough that people, when they're doing their busy shops, when they're, you know, certainly not wanting to be thinking, when you're doing your weekly shop, you're not really thinking about health. You just want to say, am I going to buy this? Am I going to buy that? It has to be really easy to use. And so there's a lot of compromises made in coming up with these scoring systems. And simplifications clearly are made. Whether we always get them right, I want to say we, it's not me, but, you know, whether the people coming up with these scores always get them right, I think is open to question, and it constantly needs to be reviewed. I mean, for what it's worth, I believe Nutri-Score is actually being revised at the moment to see if it can actually be used slightly better, because you're quite right. At the moment, it's better to compare within a food group rather than across food groups, but they're trying to improve the algorithm to see if it can maybe be used a little bit, be a bit more consistent across food groups as well. But you're absolutely right. You know, your children are exploiting a loophole there by saying, this is the healthiest chocolate, and look at that horrible unhealthy salmon. Yeah, that's not really quite true. And that's not really the way that Nutri-Score has been developed. And, you know, I suppose all I can say is that you're going to still have to be a mother here, Nicola. You're going to have to be forceful with your children and say, no, I know best. I know chocolate. Even A-class chocolate is not maybe as healthy as some of the other things that we can find on the supermarket shelves.
Well, you know, I don't know whether I should conclude from this event whether my children are health illiterate or, on the contrary, very literate. But regarding that, Peter, and I still have, we are running out of time, and I still have a few questions from the audience. But I do have one question about the scoring, the HLS 19, because I thought with these questions, right, and Mark pointed that out at the beginning, health information can be really complicated. So, and basically, if I understand the indicator correctly, it's if people say, oh, I find this or that very complicated, for example, understanding what's the right treatment for disease, then sort of the indicator concludes health literacy is lower. And I have questions concerning that, because sometimes, you know, the information we actually have is so poor that if somebody says it's difficult to know, then perhaps they're, you know, they're literate. So I don't know, perhaps you can explain a little bit how the definition of health literacy here. I think you said it's also about how the system communicates with people. It's not about the receiver, it's about the sender and the receiver, but I think that would be fascinating to know.
Yeah, thank you, Nicola. This is actually a question discussed a lot in the scientific community around health literacy, how to measure this. And the HLS 19 and the previous projects decided to measure the fit of the person with the information available or not available. So it's more about how this fit together. To bring a simple question, a simple example here, if a doctor is speaking to a patient and the patient don't understand, whose problem is that? It's not the problem of the patient, actually. It's the problem of the doctor to be understandable, to speak in plain language, to have the right information for themselves. So all of us speaking about uncertainty, we know that we did with Switzerland, Germany, and Austria just a study on the health literacy, professional health professionals. And you see there are, especially in knowing what is the last evidence-based information, many health professionals have their difficulties. So they have to decide under uncertainty and how to communicate that. So that's the problem with the concept of health literacy, that people think it's about persons, but it is about the quality of information and the fit of people to that. So It's, of course, how you use what kind of language you use. We already had this word of plain language here. It is about you find the right media and language for the specific target group you have. It is the question, is it independent, the information, especially if you are in the economic situation of medication, for example. We have in Austria done a small study, and 90% of the information you find at your family doctor's office practice is coming from the industry. It's not independent information. And if people, as you just said, Nicola, if people say, I'm uncertain about how to appraise an information, this might be the right judge. So it's not about the health literacy. It might be the very intelligent observation of people that these informations are not really reliable. Mm-hmm. So so that's the strength of this measurement, is that you point to the real problem, which is, do the people have reliable, understandable information? And not, are the people stupid or intelligent? You know, it's not this question. Of course, there is some part, but for a policymaker, it's much more important. Do you have the right information for the real people in your country?
Yeah, thanks, Peter. That's very, very important. And yet I have a further question from you, from the audience. So somebody was interested whether you have some key performance indicators for your program. And I think you can't see it. It was a direct message to me because you're looking at the chat. Key performance indicators, perhaps you can say something about, because Peter was referring to really impressive improvement in health literacy. So are you trying to assess the impact of your program, and can you see some success there?
Yes, yes, of course, we evaluate our programs, and especially I took the example of Moi Sans Tabac. Every year we have a set of indicators that we follow, which are based on the number of subscription to Moi Sans Tabac, but also thanks to our representative surveys, we follow the number of quit attempts which are provoked by Moi Sans Tabac. We've showed for the first edition of Moi Sans Tabac in 2016 that, well, the social marketing campaign was effective in prompting smokers to make a quit attempt. So it's been published in an international paper, tobacco-induced disease. I can share the reference if some of you are interested in the chat. And also, I would like to say and to take this opportunity to thank OECD again, because we are very lucky in France. OECD has conducted a very useful and important evaluation, economic evaluation of the global tobacco control policy, which has been set up in France since 2016, including Moi Sans Tabac, with a special study on the cost effectiveness of Moi Sans Tabac. And well, it showed that Moi Sans Tabac was a very cost-effective, or I'd say that the return on investment was very high, as for every euro invested in Moi Sans Tabac, 7 euros were spared in the health expenditures at long term. So that was a very useful study, and I can share the link towards the OECD website where this study is on display. I think the report has been published in June this year. I think it's only in French for now, but of course it will be available in English as well. And if you want to read it in French, it's possible. So thank you.
Again, important what the information is that's being sent and how to direct it to the right audience. Yes, please, Viet, do share. And I wanted to say, because people in the chat have shared a lot of interesting papers, did want to point out, and Mark doesn't know it yet, but assuming that he agrees, we always prepare a little web page where we share the recording, the slides, but also relevant studies that people have shared in the chat. And and also a link, of course, to the report. And we are we are past the end of our time, Mark, but I do want to give you an opportunity because the OECD, of course, is about best practices and country examples. And I was wondering whether you have some other examples. We heard from France, from Austria and WHO activities. Are there other good practices that you could share for us to go home with some, some energizing information?
To go to a slightly different set of countries that we normally go to, I think Mexico does some fantastic stuff actually on food labeling, nutrition, communication around there. So I think Mexico is definitely one, and in a slightly different angle, and with some, not 100% endorsing this, but I think some of the things that go on actually in Japan are very, very interesting, especially the way that they use employers as a way of reaching people who maybe they wouldn't normally reach, and actually the way that they use the workforce health checks as a way of communicating about health issues and about what individuals can do, but also how to change the workplace environment. I think they're well worth looking at. So yeah, they would be the two, moving outside of the normal, European lot that which are fantastic. I mean, don't get me wrong. I mean, I'm saying they're fantastic too, but I think Mexico and Japan are both well worth looking at.
Yeah, and I think Mexico is important, right? Because they have a lot of issues with obesity. So it's important for them to act on that. And it's good to hear that they have some successful programs. Yeah, so Mark, I don't know whether, I can't see whether the Deputy Secretary General is there, but also Peter, Ola, Viet. This was fantastic. I learned a lot about health literacy and also about programs that seem to work. We had a fantastic audience too that was engaged, asked questions and shared material. As I said, we will send our link to our little website once it's up to everybody who listened, and also to those people who in the end couldn't make it. Thank you very much. And I'm looking forward to further events on different aspects of literacy, because this has been very instructive. Thank you very much.
Thanks for the invite.
Thank you so much. Thank you.